Christopher Ashley. I'm going to speak with you about colorectal screening during the COVID-19 pandemic. This presentation will address the following: cancer screening recommendations from the American Cancer Society and the general flow process for the handling of immunofecal histochemical blood test positive specimens. The learning objectives are: at the end of this presentation, participants will be able to cite recommendations from the American Cancer Society with regard to colorectal cancer screening, identify patients who should receive higher priority for screening, and cite general flow processes for the handling of immunofecal histochemical blood test results. This information is presented using information provided by VA Newsletter, July 8th, 2021, Volume 5, Issue 1, and the American Cancer Society Guidance on Cancer Screening during COVID-19, and the American Cancer Society Promoting Colorectal Cancer Screening during the COVID-19 Pandemic information. The prevalence of colorectal cancer in the US it's the third most common cancer cause of death among men and women in the US. COVID-19's impact on colorectal cancer screening. According to the American Cancer Society, at the beginning of the COVID-19 pandemic, there was a 90% decline in screening colonoscopies as healthcare facilities were put on lockdown for elective procedures, as most screening procedures are elective. 4 months into the pandemic, the decrease in screening colonoscopies were at roughly 36% below pre-pandemic levels. Trends in colorectal cancer screening over the past 15 years. There has been a 30% decrease in the incidence and mortality rates of colorectal cancer in the US among adults 50 years and older, those who are most often subject to screening. Colorectal screening has contributed substantially to this decline. Because of decrease in screening rates, the previous decline in colorectal cases may be reversed. Cancer screening is critical to staying healthy and well and should not be considered non-essential healthcare. It is estimated that 1 in 3 men and women for whom screening is recommended are not up to date on screening at this time. The American Cancer Society universal cancer screening messages are that we should identify patients who should receive higher priority for screening, and identify patients at increased risk of cancer due to genetic, personal, or family history. This is essential, as these patients should receive priority status when assigning screening appointments. Patients with a history of abnormal screening tests who may need more frequent screening or additional diagnostic evaluation should be given a higher priority status. Any patient with a new or concerning symptom should be given a high priority status as well. In the process of prioritizing patients for colorectal cancer screening, priority should be given to those with abnormal stool-based cancer screens, patients with a family history of adenomas or cancer, patients with inflammatory bowel disease, and patients with genetic symptoms that elevate risk for colorectal cancer. Family history. The American Cancer Society's universal screening messages include engaging patients in the resumption of cancer screening, which will require effective and trustworthy messaging, including 35% of Americans have missed routine cancer screening due to COVID-19 related fears and service disruptions. Patients are also delaying cancer screenings based on concerns about visiting medical facilities and associated fears of exposure to COVID-19. Also, barriers to screening include the need for a negative COVID-19 test. Delays in results can lead to last-minute cancellations. So in getting cancer screening back on track, we need to address the need to schedule missed screenings as well as those that are currently due. We need to prioritize patients effectively based on a priori risk indicators And we need to expand screening capacity to handle the backlog of missed tests as well as the current need. And we need to effectively make use of remote educational and office visit technologies in order to facilitate the movement of patients through these processes. General flow process now for immunohistochemical testing, those with positive results. FOBT testing, or the FOBT test, refers to the fecal occult blood test, which is a guaiac-based test. Throughout the VA system, we now use an immunohistochemical-based test, or a FIT test. These cards have increased sensitivity and specificity. A single-use card is recommended, but we do use 3 cards because of VHA guidelines specifying 3 cards should be used for stool card-based colorectal cancer screening testing. Once the result is received, the lab is the first to receive the result. Notification is sent to our endoscopy team locally and the primary care provider. According to the VHA directive, the primary care provider who ordered the test notifies the patient within 14 days and generally refers the patient for endoscopic evaluation through the endoscopy unit. The endoscopy team tracks the patient and the referral and follows up to ensure scheduling is completed within the requirements of the VHA directive for colorectal cancer screening and documents the outcome. All of this should be done, the colonoscopy complete, or documentation of a refusal or the patient's interest in scheduling outside of the required 60-day limit, but this does need to be documented within that 60-day period of time. Any questions?